Ladies and gentlemen, thank you very much for the invitation to give a short presentation on the prevention of cardiotoxicity and how we can achieve it. My name is Simon Wernhart. I'm a senior cardiologist in Munich, Germany, and also sports scientist. I have nothing to declare. We have to be aware of the fact that a diagnosis of cancer is an independent risk factor for cardiovascular morbidity. So, screening for cardiovascular risk factors is of pivotal importance in cancer patient care in cardiology. I'd like to structure my talk by giving you an impression of cardiovascular toxicity, which parameters we really have to take care of. Then we'll talk about the prevention of cardiovascular toxicity today, according to guidelines, and we will have a little glance into the future on how we can achieve that starting from today. Actually, cancer drugs and acute cardiovascular toxicity is defined by the occurrence of several aspects, as you can see here. On the one hand, we do have cancer therapy related cardiac dysfunction or even heart failure as a result of a drop of left ventricular ejection fraction or global longitudinal strain of at least 10%, as referred to the baseline values on transthoracic echocardiography. We also have an increase in biomarkers such as troponin and NT-proBNP, which have to be considered. Certain cancer drugs do have an increased risk of arrhythmia, especially along QT prolongation. We are talking about the new onset arterial hypertension aspects. New therapies such as immune checkpoint inhibitors have a high risk for perimyocarditis, and we do have a direct toxic effect of certain substances on the peripheral and central arteries, leading to peripheral artery disease or coronary artery disease. So this is a list of all these substances you use in oncological treatment, which can induce these toxic effects, as I've shown you, especially anthracyclines, taxanes, fluoropyrimidines, alkylating agents, and certain others. So we have to really be careful how we tackle these patients. And what happens on the biological system is shown here in this very new publication, which I can highly recommend. Apart from the cardiac aspects, we have to be clear about direct cancer-induced mechanisms of vascular injury, but we also have to consider, as you can see on the lower aspect, certain risk factors which are also present before your cancer patients enter therapy. So we have to tackle them and really address them properly before we start our treatment. This has to be considered. And the second aspect is that we don't only treat the central aspects leading to higher rate of myocardial infarction or heart failure, but we also know that cancer therapy leads to endothelial dysfunction and mitochondrial dysfunction, leading to a lower capacity of oxygen extraction during the cancer treatment process. So this also sums up to reduced exercise capacity in your patients, leading to a bunch of symptoms. So how do we tackle these issues as cardiologists? First of all, we should use a risk assessment to see whether our patient is at higher risk or not before he or she enters chemotherapy. And the HEFA-ICO score is a very good score to assess the risk for overall mortality, as you can see in this publication here, and is associated with the risk assessment. So what enters this score is actually the planned treatment. Is it potentially cardiotoxic? Do we have a history of cardiovascular disease in our patients? Are cardiac biomarkers elevated? Do we have risk factors such as arterial hypertension or dyslipidemia? What about lifestyle and previous cancer therapy? So if we have recurrence of cancer, this increases our risk of cardiotoxicity as well. And we do have a new score as we're talking about immune checkpoint inhibitors, which can also be used. This is a very new score showing you that during the follow-up period, depending on the risk score, you have a higher risk for cardiotoxic events if you achieve a higher score. what enters the score is also cardiac biomarkers, the presence of thymoma, which enhances the risk. The left ventricular ejection fraction, if it goes below 50%, is a risk marker. And we have the ECG showing that a low QRS voltage is an independent risk factor entering this score. So if you treat your patients with ICI drugs, please try to calculate this score for the cardiologist to see if this is a patient exposed to a higher risk. So this is our conventional approach as a cardiologist. If an oncological patient is referred to us, we do an ECG, we do biomarkers, which are often done in Europe by the oncologists beforehand to deliver these values. And we do echocardiography at rest, assessing left ventricular ejection fraction, as you can see here, and global longitudinal strain, which can show subtle differences before ejection fraction drops. So this should be done in every cancer patient at risk. And how can we now prevent cardiotoxicity and heart failure today? This is a position statement from the European Society showing that after oncological treatment and cardiovascular assessment, we should really talk about stabilizing cardiovascular risk factors, traditional risk factors, and not just at the very beginning of cancer therapy or diagnosis, but during the treatment process and also after cancer treatment. So if we take a look at the medication which could be used in cancer patients, well, I must say that all the drugs we use in heart failure and cardiovascular disease prevention do not have any stable evidence to be used in cancer patients. So we need more studies on that. We do have data on on two substances like dexrazoxane in advanced and metastatic breast cancer patients after initial anthracycline therapy, showing that we can lower heart failure incidence if we use this substance in a selected cancer cohort. Also, liposomal doxorubicin has been it has been shown that this substance reduces cardiotoxicity and cardiac events in selected patients. So the oncologist should be aware that also targeting the treatment process can actually help the cardiologist to be able to reduce the risk profile for cardiotoxicity and heart failure. So what about the future and where is it going now? Actually, we should improve, especially in high-risk patients, our cooperation between the oncologist and the cardiologist, and also include sports scientists apart from the typical representatives you have in the oncology boards, to not only do the baseline assessment with biomarkers and echocardiography, but also to include exercise stress testing to unmask subclinical signs of cardiotoxicity or heart failure. And this is shown here. So there is a kind of a feedback mechanism shown in prehabilitations, meaning that you should start this process before you start your chemotherapy, then during the cancer therapy, also leading to the aspect of rehabilitation and long-term maintenance. And in all these stages, exercise should be prescribed on an individual basis for your patients to really make sure that your patient benefits the most from all these aspects of treatment. And why is that important? Because we want to define the phenotype of exercise limitations in your cancer patients. I've tried to summarize this in this chart. We have the typical exercise bicycle testing, which is very cheap and easy to do. There are aspects of stress echocardiography, and in some, very rare cases, exercise MRI has emerged as a method to really unmask central limitations such as a reduced stroke volume reserve and heart rate reserve during exercise in a cancer patient, probably leading to the differentiation between high risk and low risk cancer patient. We have to make sure that we know and understand that cancer and its therapy actually leads to reduction in central processes and peripheral processes, and all these accumulate in a reduced exercise capacity, as shown in this chart here. So we have reduced peak oxygen consumption in these patients. And all the aspects of the oxygen cascade can be affected in a cancer patient. So exercise testing, especially using spirometry or a cardiopulmonary exercise testing, can really show you where in the cascade the problem is located. And based on this, you can actually plan individualized exercise programs consisting of endurance, resistance, and balance training. I don't have to tell you that resistance training has a very, very high importance in cancer patients to reduce and antagonize cancer-induced cachexia and osteopenia. So the aspect that exercise is a pleiotropic drug has been emphasized in several studies. I've brought you the most prominent ones. This is actually the Brexit trial with adjuvant breast cancer patients. You can see here that after 12 months of exercise therapy, this was a combination of resistance and endurance training. You see that the exercise group achieved much better. First, you had a decline, such as in the usual care group, immediately after cancer therapy, but then the training group went up higher and achieved a significant difference to the usual care group after 1 year of treatment. And in a very, very sick population of patients, this paper has been published in the early 2025 in Circulation by Erin Howden and colleagues, that if you exercise people before and immediately after stem cell transplantation, you come out better. As you can see here, there is a slight drop in exercise capacity, but it is less pronounced than if you don't do anything, if you just do usual care, which was like physiotherapy, but not individualized treatment. And the very last study I want to show you is the Challenge trial, showing that exercise, if it is done at a very, very low level of intervention, this was exercise training done once every 2 weeks, that we can actually improve survival over the long run, over 120 months of follow-up in colorectal cancer patients in the adjuvant setting. So actually exercise reduces mortality and needs to be considered. And this has to be taken up in a suggestion which has been published recently. If we actually don't do anything, if we just do our cancer treatment, this is the blue line of the untreated patients, we see that we have a higher risk of cardiovascular toxicity, not so much pre-treatment, but then during treatment and also post-treatment. This has been improved by implementing the approach I've shown you before, using echocardiography and biomarkers before induction of chemotherapy. So the cardio-oncological treatment shown in yellow, we have an increase during treatment. This is not very surprising, and it is lower than if we don't do anything. But if we kind of implement exercise testing and individualized training programs, if we educate our patients on lifestyle and individual risk factor stabilization, we can see that we can really reduce our risk of cardiovascular events and cardiovascular toxicity in the long run during and post-treatment, and improve outcome in our patients. So if we compare that, the current status quo showing that not even 50% of cardiovascular risk factors enter the guidelines of cardio-oncological treatment. But if we implement exercise testing and education to steer our program, we can account for almost all cardiovascular risk factors which directly impact on cardiovascular toxicity. So I'd like to come to a conclusion and try to emphasize that cancer is an independent risk factor for cardiovascular disease and morbidity. The current risk assessment includes risk scores, the HEFA-ICO score and the ICI myocarditis score, cardiac biomarkers and echocardiography. Exercise can improve cardiorespiratory fitness and, in the long run, mortality in cancer patients, and needs to be part of our approach to reduce cardiovascular toxicity. Dexrazoxane and liposomal doxorubicin can reduce toxicity in selected cancer entities and should be considered by the oncologist in a patient at risk for adverse cardiovascular events. Conventional heart failure drugs don't have a prognostic improvement. We don't have any randomized controlled trials today to show that, but trials are coming. And future risk assessment should actually include exercise testing before chemotherapy is started to unmask subclinical toxicity. And the future long-term care for cancer patients needs to address all risk factors, traditional and those I've shown you here, to improve prognosis and quality of life in our patients. Thank you very much for your attention, and I'm open to your questions now.